Assalamu alaikum. My name is Mustajab Ahmad Shah, and my road number is EP1770108. And today, the main topic which I've been given by Madam Shahana is prevention and treatment of infections in neutropathic cancer patients. And the subtopic which I've been divided is empiric antibiotic dosing, administration, monitoring concentration, and host factors influencing response to therapy. Well, first I would like to talk about the neutropenia cancer. What is basically neutropenia? First, we need to understand that what is neutropenia. Neutropenia is basically the lacking of or the absence of the good white blood cells, or known as monocytes. So basically, these cells are in present in reduced quantity, and due to presence in reduced quantity, the neutropenia occurs. So usually neutropenia occur due to the presence of chemotherapy. So if you are a cancer patient and you are getting a chemotherapy, so due to that chemotherapy, the immunosuppression is occurred. So due to immunosuppression, the good white blood cells are reduced in our body, and as soon as these cells are reduced, we are infected by different diseases. So our body gets infected, and in the case of that it usually occur after 7 to 10 days after the chemotherapy, and due to that there can be fever also, and if the fever is above 101, we call it fetile neutropenia. So we need to understand that. So let's talk about the introduction, where what does this topic say. The use of medication provides a prolonged life to the malignancy of patients through therapeutic advances in chemotherapy, immunotherapy, and bone marrow transplantation. So uh, like I've talked before, that chemotherapy is basically responsible for causing this neutropenia. So there are new broad spectrum and antimicrobial medicines and chemotherapeutic agents have been developed to fight with that. However, immunosuppressant patients have significant disruption or deficiency of one or more defenses. Like I've talked before, that due to these immunosuppressant or the chemotherapy, the immune system is suppressed, and these good white blood cells are reduced in our body, and due to that, our defenses are lower down, and in the wake of that, we can get infected by different diseases in the body. So bacteria, fungi, viruses, and protozoa may infect various sites depending upon specific immunodeficiency. So as soon as we are immunodeficient or immunosuppressed, so bacteria, fungi, virus, and many other things can infect it at different specific sites. So what is basically chemotherapy? Chemotherapy makes the human body compromised. Empiric therapy is very important to decrease the infection rate. So therefore, we use the empiric therapy to fight with the infection rates in our body. So when like we have talked about the chemotherapy, that how this chemotherapy works, and due to that we can use empiric therapy to already we can start before the neutropenia occur in ourselves. So during chemotherapy we can use the empiric therapy of antibiotics or antimicrobials to fight with the infections that can later infect us. So here's a quick glance of over neutropenic cancer in patient. So I've taken this photo from the Google. So, how does chemotherapy increase the risk of infections? Basically, chemotherapy drugs are used to treat cancers that kill them the very fast growing or abnormally growing cells in our body. Both, but in the case of the chemotherapeutic agents, both the good cells and the cancer cells both are damaged. So it can occur. So it can result in neutropenia. So here is a cycle that you can see. So basically, neutropenia can also be regarded as side effect of a chemotherapy. That means your body has fewer than normal infection fighting white blood cells. So as soon as the white blood cells are reduced in our body, so infection can uh, immediately hit us. So infection is when the germs enter your body and cause illness, because your defenses are lower down. So therefore, the infectious diseases can easily uh, infiltrate our body. So we have to understand that if you have received the chemotherapy within the last 3 weeks and develop a fever, so you need to go to emergency room immediately, and it is a same emergency situation, either cardiac arrest or maybe a septic shock. So it is as important or as urgent situation. So let's move toward my main topic, which is antibiotic dosing, administration, and monitoring and concentration. So here was all about the introduction part. So let's move towards my major part. So Here we talk about the intermittent and continuous infusion antibiotics, which are the better antibiotics to use in these cases. So during going through all the literature, I found out that the poor prognosis of the neutropenic cancer patients with bacteremia lead to conduction of open label trials. So basically, open label trials were conducted that evaluated the role of continuous infusions of beta lactam drugs, for example, ceftazidime, in the empiric treatment of the suspected cancer patients. But during these trials, it was proven that continuous infusion of ceftazidime was very potent treatment option. These beta-lactam antibiotic basically inhibit basically exhibit time-dependent pharmacodynamics activity. So we need to understand that the beta-lactam antibiotics are basically working on the mechanism of time-dependent pharmacodynamic properties. So here we have found out that ceftazidime or the beta-lactam drugs can be a good potent option for the continuous infusion. However, in contrast to these antibiotics, when we talk about the aminoglycoside, which basically exhibit the concentration dependent pharmacodynamic action. So in the case of these actions, the improved response was observed in CIV, again, continuous infusion, rather than the intermittent infusion. The total daily dose, however, was greater in continuous infusion group. But when we conclude all the necessary data and the research work or the literature, conclusion, maintenance of beta lactam concentration above MIC appears to be a rational option. However, no data yet suggests the superiority of the CIV over intermittent administration. So we can't yet suggest, or we can't yet say with solid proof that CIV is a better option, or it's superior to intermittent administration. But still, there are some data suggesting that continuous infusion can work the better of the case. However, when we talk about the consolidated dosing, so what is basically consolidated dosing? It is a once daily dose that you give one dose in one day. Basically, aminoglycoside dosing has been well researched because due to its concentration dependent pharmacodynamic property, as we know that concentration dependent pharmacodynamic properties of antibiotics are very frequently studied in the research field. So the efficacy of consolidated dosing has been very well reported due to the wide area of study. So several clinical studies for amikacin, gentamicin, and tobramycin, which are basically all aminoglycoside, depicts the efficacy of consolidated dosing. Now, this is important. That consolidated dosing has shown positive results, and it shows to improve the efficacy of the drugs. It has been also suggested that consolidated dosing can be even more effective and less nephrotoxic as well. This means that in the case of renal impaired patients, which usually get renal impairment due to the chemotherapy as well, so consolidated dosing can work in reducing the nephron headache. So it can also affect. It can also result in less nephrotoxicity than the traditional dosing which we usually use. So therefore, consolidated dosing of aminoglycosides appear to be a very reasonable option for empirical therapy. So after concluding these three options, which is the continuous infusion, intermittent, and the consolidated dosing, we have come over a result that consolidated dosing can be a better option than the other two options. However, when we talk about the outpatient administrations, so basically what is outpatient, we have studied in our course that what are outpatients which are not basically in the hospital and they are going out from the hospital and now they are not admitted in the hospital. So the continued administration of antimicrobial in outpatients has been also suggested. This means that when they were taking the antimicrobials in the hospital and after they have left the hospital, they are also suggested or recommended to take those antimicrobial even after exiting the hospital. Therefore, outpatient administration of parenteral antibiotics can be also considered. So this doesn't give them a ticket that they won't take the parenteral antibiotics even they are in the case of outpatient. So parenteral administration can also be considered in the low risk patient with close medical follow-up. However, now I'll move towards the last topic, which is the host factors influencing the response of therapy. So there are many host factors that can influence the response of therapy in the form of the neutropenia treatment. So the most significant determinant for a favorable outcome, that if you are looking for a favorable outcome in a patient which is having a neutropenia, and it is was due to the chemotherapy. So the most favorable outcome you must be wishing for that there is a recovery of granulocyte count, which is basically a part of WBC. So if the granulocytes count are recovering, so it can result in the betterment of the patients. However, other host factors which can influence is the persistent neutropenia, which tend to respond to antibiotics less favorably. So if the patient is if the patient is having persistent neutropenia, then the antibiotics can less favorably and less frequently affect those patients. So we have to move towards the other option rather than those patients that who are getting the bone marrow recovery. So after getting the bone marrow transplant or the recovery, the granulocyte count can increase and those patients can get better. And the third point and the third host factor that can influence the response of the therapy is basically a site of action. So it is very important to know that what is the site of infection, where is the site that the patient is most hit by the disease. So the site of infection also tends to play an important role by influencing the outcome. And the last part and the last host factor, which is very important, the septic shock and pneumonia. So due to this neutropenia, a patient can also go in the septic shock and pneumonia, which is usually associated with high mortality in bacteremic neutropenic patients. So this is all from my side. Thank you so much.